Welcome to Balanced Health. I'm Shirley Rose, and this is Joe Costello. Today we continue our two-part series on colorectal cancer. Last week we explored the risk factors and discussed preventative steps each of us can take to reduce our chances of getting that kind of cancer. We covered a lot of helpful information, so if you missed last week's episode, I really encourage you to order a copy. As we learned last week, a key to increasing your chances of surviving colorectal cancer is catching it early. So today we're discussing what screening tests you should get and how often you should get them. We'll also look at treatment options for colorectal cancer. And to guide us in this discussion is Dr. Dan O'Reilly. He's joined us again, and we appreciate him being here. Dr. O'Reilly is a highly respected gastroenterologist with over 20 years of experience treating digestive disorders and colorectal cancer. Thanks again for coming, Dr. Dan.
Thank you.
We'll be jumping into our discussion with Dr. Dan in just a moment, right after this week's Nutrition in the News. What do you have for us, Joe?
Well, Shirley, you know, Alzheimer's is something that's really hit home with too many of us recently.
Yes.
My favorite president of all time, President Ronald Reagan. I've got pastors, I've got doctors, had Alzheimer's.
Oh,
and
my
we
dad
saw
did.
a really sad ending.
Yes.
A recent study of 370 men and women showed a significantly decreased risk of Alzheimer's for those who have proper amounts of B folate and B vitamins in their diet. Now, we're saying B vitamins is going to stop Alzheimer's, no, but what the study does show is that eating fresh foods, fruits and vegetables, does supply with the B vitamins, and if it can help you, if it can give you any edge whatsoever in Alzheimer's, why wouldn't we do that?
Yes, because we're all living longer now, and they're saying that past 65, I think your chances of getting Alzheimer's really goes up. So
That's
anything
such a
that
sad
we can
thing.
do.
You said your father had it?
Oh, my father had it for 7 years before he passed away, and really, he might have lived a lot longer. He just happened to fall and kind of broke his leg and deteriorated in the hospital and wouldn't eat and passed away. But I mean, he might have lived many more years with Alzheimer's. It was very, very sad.
To think of my father or mother not being able to recognize me, that is just a really
Well, my dad
thing.
never got to that point. He could always recognize me, but he thought I was still a teenager because he would always tell me to get home on time.
Well, maybe you look like a teenager, Shirley.
Yeah, right.
That was really it.
But that's interesting, B12.
B12 and just the B vitamins in general. I've seen so much stuff. In fact, Dr. O'Reilly had mentioned to us off air about certain types of dementia being caused by B12 deficiency, correct?
Sure. It's one of the treatable forms of dementia. If you can identify a patient who malabsorbs vitamin B12, a condition called pernicious anemia, supplementing with B12 injections or nasal spray will sometimes reverse that process. So it's an important thing to look for in the patients who are beginning to suffer from Alzheimer's disease.
Let's give just a quick recap of last week's show for those who could not join us. We mentioned that my husband Jerry had colon cancer 25 years ago. You were his doctor. You just kind of randomly suggested that he get a colonoscopy because back then it wasn't so much a preventative test as it is today, and it saved his life. So tell us a little bit what it is and what we should do to prevent it.
Well, as we talked about earlier, colon cancer is the third leading cause of cancer and cancer death in this country. It's a malignant growth in the large intestine, the lower portion of our digestive tract, often called the colon, the lower GI, the lower intestine, the bowel. And it's because it's so common, because it's preventable, it's something that we need to talk about more and encourage people to get screening tests to try and identify.
Yes, absolutely.
In these screening tests, we talked last week, and you talked about polyps. I had a colonoscopy originally because I had occult blood in my stool. I went for a routine physical, and so he told me to take this kit home, and I checked my stool for several days, I believe it was, and it was positive each time. So he went ahead and had a colonoscopy, and I didn't have polyps, but I had actually hemorrhoids in my colon. I didn't know you could have hemorrhoids in your colon.
Wow.
Well, hemorrhoids are in the rectum. They're in the last delivery zone from the colon, right before your waste material exits your body is where the hemorrhoids form. Actually, a normal part of our anatomy. We all have hemorrhoidal veins, which is what they are, they're blood vessels. When they enlarge, they can become a problem. They can thrombose, they can bleed. And so hemorrhoids per se are not an abnormality unless they begin to cause problems. And typically they'll bleed or thrombose, which causes people to have pain and irritation down there. In and of themselves, not a problem in the sense that they're benign. When we're looking for blood in the stool, we're much more concerned about the finding of polyps or cancer. So the presence of blood really is an indication to do something more detailed, such as a colonoscopy, to try and find if there's another reason for the blood.
This home kit that I spoke of, is that something you would advise people to go to a Walgreens and get, or is that something that you should wait to have your doctor say, you know, I think maybe you should do this?
It's certainly the simplest screening test we have. The problem with fecal occult blood testing, which is what you're referring to, Joe, is that it's probably the least accurate test we have for screening in terms of colorectal cancer. There are false positives, false negatives. False positive patients have blood in their stool, but they don't have cancer. False negatives, patients don't have any blood, but they have a cancer. Jerry was a good example of that. We tested him in the office 25 years ago. He had no blood in his stool, but turned out to have an active cancer in his colon. So it isn't a perfect test, and we talked a little bit off camera about whether the rectal exam and testing for blood in the office is still part of a complete physical. I think it is. Not in the sense that it's a great screening test, but I think it opens the conversation to should we be doing something more than just doing a rectal exam in the office or just testing for blood. And if you're going to rely on fecal occult blood testing, you should do 3 samples on 3 separate days, do it at home and bring it to your doctor, let him test it in the office, and then any one of those positives should prompt further evaluation.
Well, you were saying that the reason that it's not done so much is because not only is it inconclusive, but you said the doctors really want their patients at a certain age to go get a colonoscopy because that is the best test. Can you tell us what that would involve?
Well, ideally everybody would have a colonoscopy at age 50. Certainly everybody with average risk factors for colon cancer. Some people don't get those, and so we do recommend some of these other screening tests as an alternative. But all things being equal, by age 50, all of us should have a colonoscopy, which is the camera test. It's the test where we put the patients through a bowel cleansing the day before, and then we put them under sedation. We advance a camera up through the colon. We directly examine the lining of the colon, and we're able to remove polyps and take pictures and biopsies while we're there. It is considered the gold standard for colon and rectal cancer screening.
And we should say it is not painful. I mean, it's invasive. It takes a day or half a day or whatever, but it's not so bad.
You need to clean out, or?
No, I'm talking about the actual test.
Yeah.
Well, like I tell my patients, don't worry, this won't hurt me a bit. It is, certainly the prep is the portion of the exam that patients dislike the most. It's clear liquids for 24 hours. It's taking a variety of purgatives and laxatives to clean yourself out. During the procedure, you're under sedation. And most patients have little recall of the procedure afterwards. If you're adequately sedated, you probably won't remember. And it can be a fairly pleasant experience. Most people are willing to go through it a second time or third or fourth because they don't have much recall for the event.
Yeah, I think if you find a polyp, they may actually remember a little pain.
The longer the procedure, the more likely they are to remember. So if we go out beyond that 20-minute mark, which is kind of the average length of time, the sedation begins to wear off, and some of those patients may wake up. And if we're removing a polyp or several polyps, we're getting out to the 30, 40-minute mark. Frequently those patients will begin to stir, and then they may recall the procedure afterwards.
I see.
Now, if you do 100 people, I know you read the statistics earlier, but say in your office, if you did, because people are out there going, maybe I should do this, maybe I shouldn't, what can they inspect? Let's give them some hope and positive attitude for odds. If you do 100 people, how many of those people are you going to find something serious in?
Well, we talked about the lifetime risk of colon cancer is about 5 to 6% for all comers. Now, that doesn't mean that 5% of people at age 50 are going to have cancer. We're talking about a whole lifetime. Okay. However, during screening colonoscopy, the data suggests that you ought to find something about 25% of the time. So 1 in 4 patients ought to have something, either a precancer polyp or a non-precancer polyp. That doesn't mean all of those would have developed colon cancer down the road, but it is a significant finding. And we're now knowing that not all cancers even present as polyps. Some of them will present as flat lesions in the colon. So we need to study the colon closely. We need to biopsy things that look abnormal and follow up on the abnormalities. But about 25% of patients will have an abnormal finding on a screening colonoscopy. They have no symptoms, no findings, no blood in the stool.
That is a high number of people.
Well, Shirley, we need to go to break. When we come back, can we touch on those polyps again? Because I'd like to.
Sure,
I'd like
absolutely.
to differentiate.
Well, and for more information on today's show, visit tln.com, click on shows, and then go to Balanced Health. Or to get a copy of today's show, give us a call at the number of your screen on your screen. And when we return, we'll continue our discussion with Dr. Dan. So don't go anywhere. We'll be right back.